Thank you, everybody, for joining us. And why don't I get my slides? Let's just find those, which I understand that you all have them or should be able to access them. So I'm not going to be slavish about reading out every single point on it, and you'll forgive me if that's the case, because I know that, and as you'll see, I've got lots of them, and so we want to make sure to get through things. So this is just my contact info. Feel free to follow up. Email would be the best option. By all means, feel free to look at our website. I just want to acknowledge various funders of some of the research that I'll be touching on, or that have funded some of the research that my colleagues and I have done over the years. And also, obviously, thank you to all of the participants, older adults who have been involved in our study, and to all of my research assistants, trainees, and colleagues. So today we'll focus a bit on the epidemiology and risk and resiliency factors associated with risk for suicide among older adults, talk a little bit about a humanistic approach to suicide risk assessment and response, and a little bit sharing with you a little bit of what the research evidence tells us and the need for knowledge translation across a variety of levels, from the clinical level that we're mainly familiar with all the way up to population health or public health levels. So I thought we could start with a few multiple choice questions, and I think Farah will make those available to you now. There we go. So take a minute or two and just quickly go through and select what you think the right answers are for all of them. And as is often the case with these sorts of things, there might be a couple of right answers, so we're looking for the best answer out of those. Great, I see people are starting to respond.
Someone's just saying there they can't select the submit button.
Okay. Well, then you automatically get 100%. Just scroll down to see that people are getting through the various ones. Interesting answers.
Oh, maybe some people aren't scrolling. Sorry about that. It looks like some people aren't scrolling down to click the buttons
on
all the questions.
Yeah, we've got 7 questions in total. So why don't we give it another 30 seconds? Makes this the lightning round, I guess. And realize I probably shouldn't have pulled the questions out of my slides, because then I can't focus on them, but I'll read them out to you so you've got them. Okay, why don't we say 5 more seconds? 4, 3, 2, and do I click stop share? Or no, how do we stop that? Okay, share results. There we go. Do I have to click something at this point, Farah?
No, I can stop sharing if you want.
Great, great, great. And let's see the results. Okay, I can't quite see the result. Well, why don't I just walk you through them quickly? So the first question is, which of the following statements is most true? Men in their 70s and older have suicide rates more than double the national average, or various comparisons with adolescents, or middle-aged men have the highest number. Well, it looks like it's pretty close between 1 and 2, but the answer is actually 1, that in Canada, men in their 70s and older have suicide rates that more than double the national average. The rates aren't necessarily that much higher than adolescents overall. Generally, yes, but once you look at men and women together, it's roughly equivalent. So it's especially an issue among older men, as we'll see in a moment. For 2, the strongest risk factor, And of course, all of these contribute, and I appreciate the fact that everybody's very sensitive to the issue of social isolation. It's actually previous suicidal behavior. One of the best predictors of future behavior is past behavior. And if somebody has tried to end their life before, that tends to be a strong predictor of future behavior along the same lines. That having been said, it's important to remember that just because somebody may have tried to end their life before does not mean that a fait accompli they're ever going to again. And that's something to bear in mind. 3, which of the following have been shown to increase risk for suicide and for MAID? And I see people, of course, have noted pain and suffering. Interesting, nobody believes that depression increases risk for MAID. I will say, and I certainly don't want to be difficult, but it does. As do loneliness, feelings of meaninglessness, and feeling like a burden. So you guys got it right, or everybody got it right, that all of the above is in fact what we're looking for. A few clinical trials exist specifically for suicidal older adults, but what do we see in terms of either reducing suicidal thoughts or the likelihood of repeating the behavior? And again, you're smart with selecting all of the above, because really, I mean, there isn't a massive literature on any of these interventions. The most that we've seen are either cognitive therapy or actually interpersonal psychotherapy. But there really haven't been a lot of projects or studies comparing head-to-head therapies, and we know that they all can be helpful. Research suggests, research on depression, that, and these are particular studies, there's nothing unique about Japan or Italy, but that community outreach interventions help prevent suicide, absolutely. Which of the following is false regarding late life suicide risk? You got it. Asking about suicide will plant the idea in an older person's mind. It is not the case. However, if you do ask, you run the risk of actually finding out if they're thinking about it. But make sure to have approaches and processes and regulations in place to know what to do next. And finally, in terms of item 7, which of the following is a key message in the field of suicide prevention? And it looks like people really like when assessing suicide risk, it's better to be safe than sorry, which, that obviously I did a good job in throwing you off with that one. Of course, we do want to be safe rather than sorry. But the one that actually appears frequently is suicide prevention is everybody's business. And the importance of that, of course, is that it doesn't fall to any one provider or any one professional or any one person to prevent somebody's death by suicide. Of course, we all have a role to play, and it's true societally that a number of people have a role to play. And in terms of healthcare teams, we really want to get across that this should be team-based work, that you should never be asked on your own to take sole responsibility for somebody else's health and well-being, especially regarding suicide risk. So thank you, everybody, for that, for playing the home game or the office game. And we'll skip ahead. Let me just make sure that this will allow me. There we go. So this is, in fact, a poster that the International Association for Suicide Prevention has been using for years, essentially to let us know that suicide is so common that we essentially lose somebody every minute somewhere in the world to suicide, which means that every minute, one or often many more people are bereaved and have to try and make sense of it. Now, I will say over the last number of decades, there's been increasing focus on suicide as a public health issue and employing a public health lens. Now, my colleagues at the University of Rochester, where I worked some years ago, especially like the work of epidemiologist Jeffrey Rose, whose theorem, Rose's theorem, says that a large number of people at small risk can give rise to more cases than a small number at high risk, meaning although it's, of course, important to focus on people at imminent risk for suicide, that's likely going to lead to a smaller number of people, smaller number of lives saved, than if we focus on a larger population with less risk. Now, that having been said, and I sort of already alluded to this, it doesn't mean that we should only focus on people at low risk. Obviously, we have to focus on people at moderate risk, and definitely clinical care is necessary, emergency care for people at exceptionally high risk. Now, the US CDC, Centers for Disease Control and Prevention, in addition to focusing on COVID, as we all have for far too long, have identified 4 steps to a public health approach to violence prevention. And I'd argue these are, of course, highly relevant to suicide prevention. We need to define and monitor the problem, have the sense of the scope of it. We need to identify risk and protective factors, develop and test and then roll out prevention strategies, and assure widespread adoption. And there can be challenges at all levels, but step 4 tends to be one of the most challenging ones. But of course, sessions like these are designed to help with that. So we'll generally touch on these 4 as we move ahead. So in terms of the scope of the problem, and I've never presented it this way before, and just, so you know what I've done, I took the numbers, divided them by 365, so we get essentially—
Hospital to home, Jessica speaking.
A picture of what happens on a daily basis. So looked at that way, every day in Canada, we lose roughly 11 people to suicide. Now, the truth is that's an underestimate, but that's based on national mortality statistics. Of those roughly 11 people, 9 to 10 of them would likely meet criteria for a mental disorder if assessed. Some would argue it's a little bit lower than that, but roughly somewhere around 80 to 90%, especially of older adults. So that's where that comes from. 8 are male. Roughly 75% of deaths by suicide in Canada are by men and boys. 4 would be in Ontario. 2 would be over the age of 65. And I think it's something like 1.4 would use a firearm. And of those who use firearms, they're almost all male and likelier to be older men. So just to give you a bit of a sense, sort of every day, this is what we're looking at. Now, in addition to that, however, an additional 28 people die by MAID, medical assistance in dying, most of whom are over the age of 60, and about half of whom are women. So I mention that because although we know that MAID and suicide are defined as distinct entities, MAID data are kept by the Federal Ministry of Health, whereas suicide data by Stats Can, and we can think conceptually of the difference between the two, there is considerable overlap among them. And I would argue so much so that we really can't talk about the issue of suicide among older adults in Canada without simultaneously thinking about MAID. And that's only going to increase in coming years as people with exclusively mental disorders will be able to access MAID. Now, according to the WHO, about 700,000 people lose their lives to suicide every year. It's about 1% of all deaths worldwide. Although 1% seems to be a small number, 700,000 is a massive number, reflecting more lives lost than to war and homicide combined. Now, that's actually a lower number than we've seen in previous years. Not that long ago, we were saying over 1 million people die by suicide every year. So this actually suggests that suicide prevention strategies and approaches may be effective, and in fact are being effective. And we'll come to that right at the end, but it's something like a 36% reduction in deaths by suicide worldwide over the last 20 years, which is pretty astounding. There is an unfortunate caveat, though, and we'll get to that in a bit. So suicide affects everybody. Nobody is immune. That having been said, it's not distributed equitably or equally around the world. It varies by country, geography, social stratum, profession, age and sex. We'll talk more about that in a little bit, culture, identity, etc. The costs are staggering. If we look at the financial costs, one study 7 or 8 years ago, looking at data from 2010, said suicide costs this country $2.9 billion a year. That obviously will have gone up. But of course, the true price is that of loss of human life. Now, focusing on older adults, we all know this, the older adult population is growing around the world, in part due to reduced mortality to childhood illness, and except for the last 3 years, major infectious disease. So in fact, we still don't know a sense, or at least I haven't seen anybody say what we anticipate the final numbers or the final impact of COVID will be on older adults. But as we all know, COVID has inequitably impacted older adults. Nevertheless, we anticipate up to 1.5 billion people being over the age of 65 within the next 25 years, 1 in every 4 or 5 North Americans will be over 65. We've never seen this before in our lives. It'll be unique in history. As we see 100 years ago, less than 5% of Canadians were over 65, and we're moving up to the 20 to 25% range. Now, in addition to this, as we look at different birth cohorts, in this case, the baby boomers born between 46 and 64 have higher rates of suicide and always have than their parents and grandparents, which means we're looking at a high-risk demographic moving into a period of life when risk is high. As a result, no surprise, we're seeing an increasing number of deaths by suicide. Now, looking at sex for a moment, my colleague Sylvia Canetto in Colorado came up with the term gender paradox of suicide to acknowledge the fact that women are more likely to engage in suicide behavior or attempt suicide, but men are more likely to die by suicide. One of the reasons being that men use much more highly lethal means of suicide, including firearm. And in fact, firearm use is one of the most common means used among older men, men over 65 in this country. Very few women over 65 use firearms when suicidal in this country. And we've already heard about the 75% or more being men. So as we look at North American data, of course, 10 times as many people in the US, so they have 10 times as many losses to suicide because the rates are similar. They're actually a little higher there now than here. In the US, just under 46,000 deaths by suicide in 2020. 80% were men. Here, just under 4,000, 75% were men or boys, as we can see here. Males are this top line, females the bottom. Overall in the middle, and StatsCan only presents on males and females, but we see almost nothing up to age 12 because children are considered to be incapable of forming legal intent. Yes, some children do take their lives, but they're typically not categorized as suicide. So then we see an increase beyond age 12, a plateauing with really high risk in midlife for men and women and overall. Rates start declining into early older adulthood. For women, rates tend to stay low. For men, they turn around by about mid-70s and increase and increase and increase. So the highest rates of suicide in 2020 were men in their 90s. If you look to the States, you see a very similar thing. In fact, even more pronounced. So I will just very quickly say that suicide rates actually underestimate the true number who die by suicide. And I've heard various regional coroners over the years in Ontario say the true number in Ontario among older adults could be 50% higher, maybe even double. And things have become complicated further with MAID legislation, in part because MAID is not counted as suicide, it's counted as something else. And you've got to look, as I mentioned before, in different places to look at the full picture. One thing I will say, there has been a question of whether we would see change in suicide rates due to the pandemic. There, in fact, has been a slight reduction. I mean, 10 to 15% isn't slight. We would be jumping up and down if we intervened in some way that reduced that many deaths by suicide. So there was a reduction in deaths by suicide in the first year of the pandemic in Canada, but older adults did not appear to benefit from that. There was no reduction in suicides for older adults. In fact, there was a slight increase. And as we see, again, we talked about the population growth leading to more deaths by suicide in older adults over the last 20 years. In 2000, 3,600 deaths by suicide. In 2020, 3,800. That's a 6.5% increase, although it has not been linear. It's kind of gone up and down. But for older adults, it's something like a 64% increase over that period of time, which is a massive increase. As you can see here, these are just older adults, meaning I've removed people under 65, and you can see an increase from 400 in 2000 to nearly 700 in 2014, but in 2020, about 650 or so. And in the US, similarly, they saw a massive increase. And again, these figures don't include MAID, whose average age in Canada was 76 years. And to give you a sense of it, there has been a massive increase in the number of Canadians who have accessed MAID over the last 6-7 years. As you can see, the first year in which it was legalized, there was a little over 1,000. then 2,800 the next year, 44, etc. So these are massive year-over-year increases. So even though we would say COVID may have led to a slight reduction in suicides across the life course, it has not been the case for older adults. And in fact, we've seen a massive growth in MAID among older adults. And this is just to show you the age distribution. So 65 plus here, men, women. Okay. I will skip ahead because I know we've got to like to cover a bunch of things and running low on time. One thing I will say, though, is that the government's noted that people who requested MAID, the commonest reason they gave was intolerable physical or psychological suffering caused by the inability to engage in meaningful activities, suggesting something that we might do to help people who are contemplating MAID, or to think about upstream approaches to prevent people going down that road. So one thing that's important is that psychological problems are not inevitable with aging. We don't become depressed just because we get older or develop anxiety disorders. These are conditions that can be identified, diagnosed, treated. But there is some percentage of older adults who do suffer with mental health issues that can increase risk. As we're thinking about risk and protective factors, in these slides that you see with a little yellow at the top, are taken right from the Canadian Coalition for Seniors' Mental Health's late life suicide prevention pocket cards. So older adults at risk for suicide, including those thinking about suicide or who have engaged in the behavior, who have a family history of mental health problems and or suicide, who struggle with psychopathology, mental disorders and or personality disorders, or extreme or rigid personality factors, who suffer from some medical illnesses, including pain, generally not terminal illness, although certainly that can increase risk, a variety of psychosocial factors, including negative life events and transitions, and functional impairment. But it's always important to focus on the flip side, positive factors that might reduce risk, as you see here, spirituality, social connection, optimism, and what many of my colleagues and I have focused on is cultivating a sense of meaning in life. So it's not enough just to sort of tick off some in column A, some in column B, but to have some understanding of how they combine in the individual. And my colleague Gord Flood and I developed this sort of schematic saying, we know that certain biopsychosocial risk factors can directly lead to increased thoughts of suicide, either on their own or through negative events, losses, and transitions, which could potentially lead to more suicidal behavior and deaths. But that positive factors, resiliency factors, factors that allow us to feel more buoyant, to bounce back from stressors and challenges, can in fact decrease the likelihood that we'll think of suicide or go down that road, and might even decrease some of the negative events or improve our response to them. Now, suicide risk assessment, I'll talk a little bit about risk assessment and response and finish up with a few public health thoughts and then maybe move on to the next stage. So in assessing suicide risk, we have to do so sensitively, ideally in the context of a trusting therapeutic relationship. Just reading out questions to somebody and ticking down answers or ticking off answers is not a good way of doing it. It's important to assess in the context of some therapeutic rapport, which means relying on our skills to develop that fairly quickly, especially if we're assessing somebody the first time we meet them. Obviously, work within your skill set. Not everybody has a great deal of training in assessment using psychological assessment tools and the such. And I'll just mention that one of the first contributions that I had made in my career, really as part of my doctoral dissertation, was developing a measure of suicide ideation specific to older adults, which we call the Geriatric Suicide Ideation Scale, which we've recently abbreviated. There are some process issues. I won't talk about those, but you've got them in front of you in terms of, again, developing rapport, respecting the dignity of older adults, and the sorts of things to ask about. You might want to reach out to collateral informants as well, family members, friends of the older adults, other healthcare providers. Ask about what's going on in their life, how they're doing, and then work your way up to explicitly asking about thoughts of suicide, wishes to die, presence of a plan, how they felt previously, what they've done when they've had these thoughts in the past, and what gives them reasons for living. In terms of the question, can suicide be predicted? I think in retrospect, we can see the signs of, but suicide prediction requires massive numbers because it's a low base rate phenomenon. So statistically, we are likely not going to be able to identify which individuals are going to die by suicide. Some people are putting their faith into machine learning approaches. We'll see. I'm not quite so sure about that, but we'll see. It certainly might help. The important news is that suicide can be prevented. I won't talk about this for now, other than to say that we can prevent at a variety of stages in the process. Prevention in suicidology, we mean before somebody's at imminent risk. Intervention is when someone's in crisis or risk is present. Postvention, after they've either engaged in suicidal behavior or even after someone's died by suicide, where we reach out to the survivors. And we can think about it at population levels, community levels, and individual clinical levels. And just to say, there are examples in the literature of all of these having some effectiveness. So effective approaches can include enhancing education, community outreach, restricting access to lethal means, including guns, alcohol, drugs, suicide hotspots, and other such things, improving access to and delivery of effective mental health care, collaboration amongst providers and with older adults and their supports, enhancing systems of care, not forgetting that grassroots efforts can be extremely effective, screening high-risk demographics, etc. I'll say that there has not been a large number of randomized controlled clinical trials looking at suicidal individuals. That has increased over the last 10 to 20 years, but much more is needed. And just to sort of point out some of the medications that have been shown to potentially reduce risk in some, not explicit to older adults, and some forms of therapy. I thought maybe I'll take a quick minute to touch on these. I pulled these together a few years ago, and I thought it's important. I suspect these are values that we all hold working with older adults, humanistic principles. Human beings are more important than things. We have to respect the inherent value and dignity of our older clients, honor their wishes to take an active role in their lives and communities. We need to recognize that everyone is unique. We can't use cookie cutter approaches. We have to really individually tailor what we do to the individual, sitting with us, in front of us, on screen with us, or whatnot. We need to take the time to really listen to our clients, learn who they are, what matters to them, their history, hopes, experiences, and what can help, including what makes life meaningful for them. Ask ourselves, how would I like to be treated if I were in their shoes, and try and do that. Focus on the here and now, what's going on in their lives now, but be open to the fact that many of us, as we get older, tend to reflect and reminisce more, but also focus on the future, and that growth in human development does not stop at a given age. Aging is as much a state of mind as of body or time. A couple of final thoughts. We don't do a wonderful job of training healthcare providers, including mental health providers, to assess and respond to suicide risk, and we need focused training to do so. And I've already mentioned some work with my colleagues with the Canadian Coalition for Seniors Mental Health. We developed a set of late life suicide prevention tools some years ago, and we'll hopefully continue to update them over the next while. These include a set of national guidelines. This is a clinician pocket card. I read you some of the pieces from it, a guide for facilitators, an interactive training DVD, and then a guide for family members. I'll say that some years ago, we developed half-day workshops focusing on those tools to train frontline providers and working with older adults, and we saw significant improvement in knowledge and change in attitudes toward the better, arguing that a combination of knowledge, positive attitudes, and professional skills and experience can potentially lead to increased competency in working with at-risk older adults. And I will say that my colleagues and I got some funding about a year ago from CIHR to adapt that approach specifically to screening for suicide risk among older residents of long-term care homes in Ontario. and you'll see the various things we're focusing on. For those who are interested, feel free to drop me a line and follow up, especially if you work in long-term care. Now, if you work in long-term care outside of Ontario, I'm still happy to share information with you. You just might not get into the project itself, but we're dedicated to helping with that. A variety of research needs. I won't touch on all of them, but maybe I'll finish up with a few thoughts. One, I would argue we absolutely need a national strategy for suicide prevention in Canada. The idea to develop these really came out of a meeting in Banff in the early 1990s. The United Nations and World Health Organization have called for countries worldwide to develop these strategies. We don't have one, in part because health is managed at the provincial and territorial level in Canada. Nonetheless, it's something that we need. And the federal government in the last few years has taken on a much bigger role in suicide prevention. Some of you may have heard last week about in the current budget, massive investment specifically in a 3-digit suicide prevention line. Hopefully, they're also investing in a variety of other things. Do these strategies work? Well, as I said at the outset, there's been a 36% reduction in deaths by suicide over the last 20 years across the world. And you see that differs per region. However, in the Americas, North, South, and Central, it increased. So we are bucking the worldwide trend and going in the wrong direction. More work needs to be done. And this is just to show worldwide. Here, green is Europe, as you can see, Africa in blue, yellow, I can't quite see on my screen. Yellow is global. And you see this one line that's increasing, the orangish rust-colored one, that's us. So more is needed. What can we do? Treating mental health issues is obviously necessary, but we can't just be reactive and say, we're just going to, pump more money into the mental health system. I think we really do need a paradigmatic change. We also need to focus more on upstream approaches, promoting psychological health and well-being, and reaching out to communities, in part working with community members to learn from them in terms of what works well and what we can do to promote mental health and well-being, rather than constantly playing catch up when people find their way into our emergency departments. And this is just to say that there have been studies suggesting that upstream approaches can work. My colleagues and I, for the last number of years, have focused on what we're calling meaning-centered men's groups, which is a meaning-centered approach for men struggling around the time of the retirement transition, where we focus on finding meaning in work, career, productivity, social contributions, relationships, positive experiences, and generativity, or what we leave for the next generation. We're now, we pivoted these groups online over the last few years, have adapted them recently for older adults, over 60 in this case, either in Ontario retirement homes or living at home. We had one group that ended about a month ago. We've got another one starting soon. We still have room, so if you happen to know somebody, send them our way or send them to our website, as you see at the bottom there, meaningfulgroups.com. And we've got some more funding. We originally did this study for men funded by Movember. We have money from Movember to adapt and test this group with male veterans and first responders, police, fire, and EMT or paramedics over the age of 50. We are actively looking for people. If you know of some, feel free to send them our way or to our website to learn more. So finally, I will say you can look these over, but it's important to assess suicide risk, to think in a broader fashion about suicide and its prevention, including at a public health level, to screen for access to lethal means, ask about thoughts of suicide, ask about positive factors, and recognize that this is best done working as a team, and to communicate with our providers. Because if we've got a team and each team member does their own thing and never speaks to one another, that's unfortunately almost a fail-safe way of assuring that things are going to go badly. So final thought, my colleagues and I have developed a knowledge translation series. It's free. If you'd like to join, we hope to have some sessions coming up over the next few months. Drop me a line. And finally, just to say that again, as the field has moved over the last few decades into more of a population health or public health approach to suicide prevention, it's important to recognize that we not focus exclusively on large data or large approaches. We still need to focus on the clinical approaches, and we need to look at interdisciplinary ways of doing so and really developing new and innovative approaches. And final thought, at least for me, for now, we have to take into consideration the lived experience of older adults and their family and other supports and their healthcare providers if we want to truly impact the health and well-being of older adults in a positive way and not only prevent suicide, but enhance life, health, and well-being. Thank you very much for your attention. I will stop at that point.
Thank you very much, Dr. Heisel. You did cover a lot of ground there. And it looks like there's a number of questions. There was quite a few that came around medical assistance 9 and how you sort of document that on a death certificate, that sort of thing. But there was a lot of responses to that. So I think we'll focus on, a suicide risk and prevention specific questions. Where was it here? So someone was asking, Lori Engel, is there a role for the Columbia Suicide Severity Risk Scale as value for older adults?
Well, I'll say it's a good question. I am familiar with the Columbia scale. I actually was working with the people developing it at the time. I was working on a project, and those people were involved in it. It has been used largely. It was not developed explicitly for older adults. So I have not seen anybody examine it specifically with older adults. I know it's used a lot. I know it's used a lot in behavioral health settings and other settings, in part because, part of the background, without going into all of it, is that the developers of it had been commissioned by the US Food and Drug Administration to look into suicidality among people using SSRIs in some of the SSRI trials. So this is going back 20 years or so. And so when they looked at it, they discovered that it wasn't necessarily that people died by suicide. Some were thinking about it, some engaging in the behavior, and the language was all over the place. So they modified the language and created a classification system. And from that then said, now we need a tool that maps onto those terms. And because of, in part, their close connection to the FDA and the states then said, every clinical trial needs to assess these particular factors. And although they stopped shy of saying you must use the Columbia scale, a lot of people doing clinical trials have started using the Columbia scale. So it's been used a lot, but it's not explicit to or exclusive to older adults. So we will look at it in one of our studies, but to our knowledge right now, there are very few that focus explicitly on older adults. The GSIS is one, there's a harmful behavior scale, and clearly others will be under development. So it certainly may be useful, and I'll let those who use it speak to that, but just be aware that it can be very important to use age-relevant or age-specific tools as well.
Okay, thank you. And
I'll keep my comments shorter from now.
No, that's okay. It's much appreciated. But for efficiency's sake, I think I'll read a couple of other questions if I can. So Colette Panko asked, how effective are the tools or measures when cognitive impairment is part of the clinical presentation?
Yeah, that's a huge question. And the truth is, we don't have wonderful answers for that. We still don't even have wonderful answers as to whether dementia increases risk for suicide in older adults, decreases risk, or more likely the case, risk can change and fluctuate given the stage, the severity, time, and so on. In my own research, typically we've had a sort of cut point at which we'd say, okay, if somebody, and generally it was if somebody's struggling from extreme dementia, where we felt that they really couldn't participate meaningfully in a study, we would exclude them from it. In the study that we're going to be doing, that will be starting soon, it's just currently going through the Research Ethics Board in London, we will be looking at risk assessment among older adults in long-term care, which of course includes a large number of people with cognitive impairment. So we'll have a better sense of it. But I will say, even with cognitive impairment, even with extreme cognitive impairment, older adults can generally acknowledge and talk about their thoughts and their feelings, including about suicide. How predictive they are, we'll get a better sense of that as we move ahead. But that clearly is one of the upstream, the challenging questions that we've got to face.
Mm-hmm. Yeah. And Katie Little was wondering, is the geriatric suicide ideation scale available within the CCSMH toolkit?
Yes and no. Yes, in that we refer to it, and I think the instructions are reach out to Marnin for it. So what I would say is, if you're interested in using it, reach out to me. I don't charge anybody to use it. I'm happy to let people use it. I'm happy to encourage people to do so and have a discussion about how to do so, and even provide you with some support, including people training, that sort of thing. The key, though, is if you don't hear back from me the first time, keep at me, because it's just, your email is probably somewhere in a long list, and it's not that I'm trying to dodge you. So yes, absolutely, it's available.
All right. And Irene had a question around whether or not there were any similar online or in-person meaning-centered groups in other provinces, and I think she specifically was hoping for Alberta.
Yeah, well, Alberta is an interesting one, because at least in terms of our study, that is the only other province that has had one of our groups. So there was a group run in Calgary some years ago. So part of that being just in terms of the limits of our study itself, and the fact that, the limitation of the fact that although there's increased sort of ability to move from province to province as healthcare providers, we are still registered on a province by province basis. So you would need to have somebody registered in that province delivering the intervention. I couldn't do it from Ontario. But for those who are interested in getting involved in potentially having a group in your province or your community, reach out. I'm happy to talk with you about it. One of the reasons why we did offer a group, it was actually at the Kirby Center in Calgary, was because we wanted to evaluate whether we could, in fact, support somebody at a distance to run their own group and do it in a way that was consistent with the group. And in fact, it went really well.
Okay. And I think we can squeeze in one more question, and that's whether there's any help group or risk assessment available in other languages than English.
Yes. Don't ask me what they are. No. I will say that one issue in terms of our scale, and of course there are scales, in a variety of languages looking at a variety of things. A colleague in Quebec has translated the geriatric suicide ideation scale into French. Actually, the first translation of the scale, it was over 20 years ago. I was at a conference in the States, and people from Hong Kong, colleagues there, asked about translating it. So there is, in fact, a Cantonese version. A couple of items I think need a little bit of a fixing up, but there is that. I know that others have asked, or some people have sort of unofficially done their own translations, but at the very least, there are versions in French and in Cantonese. And again, if people are interested, and this is something we want it to be available, if people are interested and have facility in other languages and in translation, let us know. We'd be happy to talk with you about that.
Wonderful. Well, thank you very much for that.
Absolutely.
So we're going to move on now.